In September of 2003, with her lungs damaged beyond repair by cystic fibrosis, Sarah Murray was informed by her doctors at UHN that only a double lung transplant could save her life. The UHN's multi-organ transplant program is a leader in the medical field of lung transplantation. It began with the world's first successful lung transplant in 1983, performed by Dr. Joel Cooper and a team of surgeons at Toronto General Hospital. They followed this important achievement with another in 1986, the world's first successful double lung transplant. The list of accomplishments continued with the first double lung transplant on a cystic fibrosis patient in 1988. Assisting Dr. Cooper during this historic operation was his resident, Dr. Shaf Kashafji. Today, Dr. Kashafji is the director of the lung transplant program at UHN.
When we started out again in the 80s, we couldn't preserve lungs at all, and we did the donor and the recipient operation in adjacent operating rooms so that it could be almost immediate. Now we are able to reliably preserve lungs for 12 hours and have done so. So we can retrieve lungs from donors anywhere on the continent and be able to safely perform a transplant here in Toronto.
What has allowed doctors to preserve donor lungs for up to 12 hours is the solution Perfidex, which Dr. Kashafji and his team developed. Perfidex has revolutionized transplant surgery and is now used by hospitals worldwide.
Many years ago, most patients with CF wouldn't make it to be teenagers, and now they're living into their 30s and 40s on average. When they get to the point that the lungs don't work anymore and they're severely damaged, transplantation provides the only hope of life and quality of life for patients with end-stage cystic fibrosis.
It's an effort to do anything, any little thing that you normally do, Say you come downstairs and realize you forgot something, you sit there and think, oh my God, I have to go back up those stairs to get that. It's like the end of the world.
You start to assess someone for lung transplantation when you feel that conventional therapy has met its limit, and the only way to save that person's life would be to perform a lung transplant.
I'd made the decision to go ahead and do the assessment and see where I stood and if I was a candidate for the transplant.
Patients with cystic fibrosis account for 23.2% of UHN's transplants. In July 2003, Sarah began the demanding process of being assessed for a double lung transplant. The entire procedure is taxing, both physically and emotionally. The patient receives a medical and psychological assessment. How she will adapt socially is reviewed, and finally the candidate and her family are assessed in their ability to cope with this very unique situation. Over time, cystic fibrosis destroyed Sarah's quality of life. By the age of 25, she was unable to cross a room without gasping and coughing. She was requiring 12 to 14 hours of sleep a day. Her only hope was a new set of lungs. To maximize her chances for a successful double lung transplant, Sarah started working out at her local gym.
I got the phone call to say that I was accepted into the program, that everything checked out and I could actually go through with the surgery. And so that weekend, the Labor Day long weekend, I got very sick. I was almost off the IV antibiotics, and I, for whatever reason, started running a really high-grade fever, and my lungs just filled up with fluid and I couldn't breathe. And my parents had to rush me down to the hospital, and I was admitted and on oxygen 24 hours a day and bedridden, couldn't get out of the bed at all. They were very worried, and the surgeon from TGH came.
The surgeon assigned to Sarah's case was Dr. Andrew Pierre. Dr. Pierre first met Sarah in her hospital room.
The surgeon doesn't usually meet with the patient until the decision has already been made that they're going to be placed on the waiting list. So by the time I actually went over to meet Sarah while she was in hospital, she had already gone through the assessment and become accustomed to the idea of having a transplant.
I signed all the papers saying that I agreed to this, and they informed me at that time that I was put to #1 on the priority list, and the next pair of lungs that came in that were a match were mine.
I wanted to go over what the plan of care for the day is, and I understand, Jean, you're her primary nurse today, and the two of you.
I know when I was in the hospital, right before my surgery, and I was on oxygen, and I had a really, really bad night where I couldn't breathe, and I sat there, and I honestly thought that night I was going to die.
With Sarah now placed high on the priority list, the anticipated wait period for a pair of donor lungs was 3 to 6 months, the same amount of time that doctors thought she had left to live. Sarah was not only facing the possibility of not receiving donor lungs in time, but if she did make it to the operation stage, she would be dealing with other concerns. First, would her body accept the donor organs as her own? Second, would her body adapt to the immunosuppressive drugs necessary for transplant patients? The drugs prevent the patient's immune system from rejecting implanted organs, but suppressing the immune system can make patients vulnerable to infections and cause side effects such as kidney failure and diabetes. It is in the area of re-educating the immune system that the research team at UHN's multi-organ transplant program is focused on. Their goal, to have a transplanted organ accepted by the recipient as its own, eliminating the lifelong use of immunosuppressive drugs. Their first and current director is Dr. Gary Levy.
Dr. Khashavji has come up with a very exciting observation, and it's been reproduced by other laboratories around the world, and that is during the harvesting process, and when these organs, and in this case lungs, are implanted, there is an intense inflammatory reaction.
Somehow when the transplanted lung gets injured, whether it's an inflammatory injury or whether it's an immune injury, it responds differently than a normal lung, and sometimes not so productively. It doesn't heal with the same normal kind of tissue, it heals with more scar tissue. So we're trying to find out what is the fundamental difference that makes that lung not heal in the normal way.
How long did you develop it for?
That was a minute. It was 2 minutes.
So we now know that if we modify cells within the lung, and maybe that can be done at the time of harvesting from the donor, those lungs would be better in the sense that they won't have that intense inflammatory reaction.
The research team at UHN has established that there are 2 benefits to modifying the donor organ cells. First, less damage to organs when removed from the donor, and second, with the donor organ in a stronger state, the chance of transplant success is improved. The possibility of your body rejecting donor organs is a concern all organ recipients confront. Sarah Murray was to face this reality sooner than she had expected.